Thank you, Otenyo. I want to thank SERAM and Dr. Diego Nunez and Dr. Antonio Luna for inviting me to give this session on infections. And we'll first start with imaging of renal infections. And so we'll talk about the process of stones and its association with infections, as well as infections themselves, and talk about features that should not be overlooked. We'll start with the easy pyelonephritis, which is an infection of the renal pelvis, the calyces and interstitium, and it usually is an ascending infection from the bladder to the kidneys, and it either is ascending infection or hematogenous spread, and they usually present with fever and flank pain and an elevated white blood cell count. So we usually know what they look like clinically. Many of them are female, and the complications of pyelo is abscess formation. Imaging, we usually start with ultrasound. The goal of ultrasound is to see the complications of infection. The most common feature of pyelonephritis on ultrasound, however, is normal. And when you start seeing increased infection, you lose the corticomedullary junction. There is striation of echogenicity, and the areas that you want to think about is areas of decreased flow. It's opposite of what you think. Most inflammation is increased flow on ultrasound, but pyelo is decreased flow because of the tubule inflammation that occurs. Other things you might see is urothelial thickening of the collecting system. On CT, we call it striated nephrogram. That's these areas of striations or linear areas of decreased enhancement that correlates to the area of decreased flow on ultrasound. You may see an enlarged edematous kidney and fat stranding associated with that. So what happens with pyelonephritis if it's not adequately treated? You could see originally this patient has a edematous kidney, areas of striation in the parenchyma, and 1 week later these areas of striation become liquefied and abscess formation. There is a differential diagnosis of striated nephrogram you want to keep in mind in the setting of trauma. Renal contusion and renal hematoma may present this way. You might have a acute renal vein thrombosis that shows a very swollen edematous kidney. And in children, you want to think about recessive polycystic kidney disease, as well as in patients who've had a contrast load, acute nephrotoxicity of the kidneys can show a striated nephrogram. Also, if you are seeing these patients in the emergency room, many of these patients come very similarly with hematuria and maybe even flank pain and fever, but you want to make sure that you do evaluate these patients to follow up. You can see that this may look like pyelonephritis to you, but this actually is a patient with transitional cell carcinoma. Both these patients can mimic pyelonephritis on imaging. One of the complications that may occur is emphysematous pyelonephritis. Typically, this is your diabetic group in your immunocompromised group, and they will have typically recurrent and outstanding urinary tract infections that are not usually adequately treated. These patients are very sick. They are septic, they're acidotic, and it is a quick surgical emergency in these patients. There are different types of emphysematous pyelonephritis. We learn about the classic type, which is type 1, and that's when you have parenchymal destruction of the kidney that's replaced by gas, and the gas may be the entire parenchyma or within the striated component of the parenchyma. But there is another group that can also have gas-forming organisms, and you might think of them as perirenal abscesses or abscesses within the parenchyma, but these also are in the setting of diabetic patients, are a type 2 form and also have a very high mortality rate of 20%. And these also are emergently taken care of by percutaneous drainage or even surgery if they're quite sick. The ultrasound findings is problematic because you can imagine the gas is what obscures the detail, and you have ring down or artifact within that. If you don't see the good components of the kidney, you really need to take them to CT to evaluate the emphysematous change. As we see on CT, it is replacement of the kidneys by gas and destruction. Many of these patients, like I said, are sick, so many of them don't have IV contrast, and you are making this diagnosis by the presence of gas. One of the other confounding complications is renal abscess, and this again is in patients with the pyelonephritis that is complicated, or you can have hematogenous spread in the setting of cardiac infections and such. So most of these bugs are E. coli or Proteus-based, but some of them have these very odd fungal or fungal-like infections, which you see in the immunocompromised patient. It is the complication where you have necrosis of the parenchyma from outstanding pyelonephritis that's not adequately treated. These abscesses can perforate, extend into the perirenal space, go up underneath the diaphragm, and cause significant problems. On ultrasound, you're looking again for the areas of decreased flow for pyelonephritis, and when you start seeing areas of liquefaction and hypoechoic areas, you can be confident that that is renal abscess in that formation. The CT findings are similar to what you see abscesses everywhere else in the abdomen, where you see replacement of the parenchyma by these fluid-filled peripherally enhancing collections, many of them having gas within. There is a differential also in renal abscess, especially if the patient is not that sick. Obviously, cystic clear cell, cystic renal cell carcinoma can mimic a renal abscess, and sometimes you have to take care of the patient with antibiotics and do a follow-up imaging in those patients. But you can see how a cystic renal cell carcinoma can mimic a renal abscess. Other things can be very necrotic that can mimic a renal abscess, particularly squamous cell metastasis, and lung cancer is not uncommon to go to the kidney. It is not uncommon to see renal metastasis from a stage 4 lung carcinoma, and they can be quite necrotic on their appearance. In the setting of immunocompromise, particularly in the transplant population, you're going to be talking about other types of organisms. Nocardia, a fungal-like organism, or even fungal-like bugs can cause significant disease and mortality in these patients. You can see something small like this in a renal transplant turned out to be having to remove his transplant kidney from the significant disease that this patient had. Fungal infection occurs in the immunocompromised patient, and it can be quite diffuse. It can occur in the transplant patient itself, where you could see the large abscess replacing the parenchyma, or it can be diffuse in the setting of your bone marrow transplant leukemia patients who have systemic candidiasis involving many of the organisms. Pyelonephrosis is a complication in patients with renal infection, and you want to think of it as something called pus under pressure. That means that there is a obstructive system that is superimposed by infection. So it's a big problem where you have pus now that's in an obstructive system that needs to be quickly taken care of by a stent placement. Typically in the older patient, it's either a malignant stricture that's causing the obstruction, or if there is a big stone that is resulting in the obstruction. Think about it like this. If the urine is not able to go anywhere, bugs come and it becomes superimposed infection, and that infection allows for debris and pus in that collecting system that is not able to drain and adequately take care of the urine in that patient. With that, the patient becomes bacteremic. and septic shock, and they're unfortunately a very high mortality in these patients. So it is a surgical, the only largest or most acute urologic surgical emergency in these patients. You need to have adequate, quick drainage in a system of pus under pressure. What are the ultrasound findings? Well, you see hydronephrosis, you see debris, you see junk in that collecting system, and many times you'll see the debris and junk within that urinary bladder. The urothelium will respond to infection, and you'll see the thickening of the urothelium just like you see it with other types of infection. So here is a patient with pyonephrosis. You can see that this patient has hydronephrosis, debris, echogenic junk in the collecting system, and areas of obstruction downstream from this. If you were to put them on CT, this is what they may look like, a very ugly collecting system. There's peripheral enhancement, urothelial enhancement to the obstruction. This happened to be a long-standing stone in this older patient that sat with it to get superimposed bacteremia and urosepsis. So what happens when you have these long-standing infections and obstruction? It can cause significant disease to that kidney, where the kidney becomes atrophic. You can see that this one has significant dilatation in the collecting system, a large stone that is obstructing this kidney for a long time. It's obstructed, it perforated into the perirenal space and causing perirenal abscess. And then the patient presents with the perirenal abscess. He had this infection for many weeks at home before he presented acutely. So that takes us just for a little bit of time to talk about stones and stones in the setting of infection. And that is the reason why urologists are very quick to take care of these stones, not because so much of the hydronephrosis, but because of the potential of having superimposed bacteremia, particularly struvite stones. And struvite stones is what we know with the staghorn calculus, and we'll talk about what struvite. It's not usually calcium oxalate, it's magnesium ammonium, and these struvite stones are stones that develop and fill up the intrarenal collecting system. All right, so struvite stones equals infective urinary stones. They're the same thing. So when you start seeing staghorn calculus, you want to start thinking infection urine story. And it could be staghorn, it can be acropora, just like the linear types. It could be like coral and fill the intrarenal collecting system. And these are the infection urinary stones. And why are these important? Well, 75% of them develop complications. And that is our goal on imaging, to tell the urologist, this is a staghorn calculus, this is likely an infective stone, and they need to adequately take care of these very quickly. Otherwise, you're going to have some significant issues with pyelonephritis or chronic changes of xanthogranulomatous pyelonephritis. So you want to talk about these stones in acute complications. They can have pyelonephritis, they can have perirenal abscesses or abscesses to these stones. They can obstruct the collecting system with superimposed pus-filled urine, and you can have urinary sepsis. And you want to think about that when you see staghorn calculus. So here's a patient who has staghorn calculus, but more importantly, you have to say that there is pyelonephritis with the stone. Urothelial enhancement has to be adequately taken care of, otherwise will be big problems for this patient in the future. Here's another patient who's got a staghorn calculus, but look what's happening. There's perirenal infiltration, urothelial thickening, and then there is beginning to have atrophy of the parenchyma from the setting of superimposed pyelonephritis. Here is another patient that you might see even on MR. Look what's happened to that kidney. It's completely atrophied. It's replaced by fluid-filled collecting system with this large staghorn calculus. But there is urothelial thickening and enhancement and edema, and that is pyonephrosis. It is an infected stone producing this collection. We've all seen these patients. They've had these large stones. The stones are not moved in a good time, and they form collections within the parenchyma. You have a renal abscess. There's already perirenal infiltration. This is a problem for this kidney, and many of these have to go on for surgical excision. So that's the acute phases of the struvite stones with infection. But what happens long term if these stones are not removed? So these can cause changes of obstructive pyelo, where you start seeing atrophy, ballooning of the intrarenal collecting system, and significant parenchymal loss. And we know xanthogranulomatous pyelonephritis, that's the evolution of these infection stones with superimposed infection with Proteus or E. coli, and the very long-term end term of the infected stones is where you have complete replacement of the perirenal space and the sinuses with fat from the chronic evolution. All right, so this is what we see long-term. You'll see a patient has extensive struvite stones. There's atrophy to the collecting system, really not functional in the upper pole. And this is a big problem for urologists. Either they have to go segmentally to remove it, or they sit there and do lithotripsy 4, 5, 6 times to this kidney to remove it. And they have to answer, is this kidney worth it to do all this type of procedures? Is the atrophy too much that they just need to resect? Here is a patient with an obstructive stone, atrophy to the collecting system, a little bit of an infection around that stone. This kidney was not worth it to the urologist. It was already atrophic, has to go on to resect because this stone is infected. And so you have to remove it because that patient will come back later on with a big problem. This is what we know in the setting of parenchymal loss, xanthogranulomatous change, perirenal abscesses, big problem when you have both kidneys involved in terms of how do you manage these patients with multiple lithotripsies. Are these kidneys worth it to do that kind of surgical resection? And if it's involving both kidneys, the urologist will. So xanthogranulomatous pyelonephritis is in the setting of this chronic stone-forming stones with chronic obstruction. So chronic infection in the setting of chronic obstruction is usually what we see with xanthogranulomatous pyelonephritis, and 75% of them associated with a staghorn calculus in that images. We know what they look like on imaging: big staghorn calculus, blown out calyces from the atrophy and the parenchymal loss to it, and you can have either diffuse involvement or focal involvement. This is more focal involvement, where you can see the upper pole is involved. You can see a staghorn calculus in the upper moiety of this duplicated system, where there is blown out calyces, and this patient can be adequately resected partially from this chronic xanthogranulomatous pyelonephritis. So renal replacement lipomatosis is the end result of these infected stones. Many of us don't think about this when we see these patients. It is the end result, and so this is one of the things that we need to report on when we see these chronic changes. So what happens? You have these large stones, infected stones. It causes parenchymal atrophy or blown out calyces. And what happens is the perirenal space or the sinus of the renal sinuses are replaced by fat. And it tells the urologist this is a chronic change that is going to be a big problem in terms of atrophy and non-function to that kidney. And so you'll see the perirenal and perisinus fat the deposition in the setting of these chronic stones. So you may see on MR, this is what happens. You might say, oh, it's a chronically atrophic kidney, but not only is it atrophic, it's the reason for the atrophy is the long-standing staghorn calculus, the perirenal fat deposition from this long-standing stone that's not taken care of. And you can see non-function of that kidney. This kidney needs to be removed, especially if there's a stone sitting in there, because it can cause superimposed infection. So remember, the staghorn calculus can lead to chronic obstructive pyelonephritis and atrophy, and can eventually lead to renal replacement lipomatosis. So we may see somebody that looks like this. You're going to say there's a large edematous kidney, there's extensive staghorn calculus, there's blown out calyces, perirenal inflammation, but also that there is sinus lipomatosis. This tells the urologist, if I don't go in now and intervene, I'm going to lose this kidney from the atrophy from this long-standing infection in these patients. Here's a patient who's got lots of things going on. There is a large staghorn calculus, there's atrophy to the parenchyma, blown out calyces, there's pyonephrosis from the thickening and edematous urothelium, and you could see the deposition of the fat in this kidney that will tell the urologist to go in and remove this exam. And so that is the end of this talk, and we can take infections later.